It is now my pleasure to introduce our next session entitled The Future of Newborn Screening, presented by Dr. Andy Rohrwasser. He is the director of the Utah Public Health Laboratory. For his full bio, please see the attendee website. In addition, please reference your session screen for CEU accreditation and disclosure statements, as well as the CEU tab in the attendee website. Dr. Rohrwasser, you may now begin your presentation.
Thank you very much for the introduction and the and Mountain States for the kind invitation to talk today about newborn screening. So just as kind of an introduction, so my objective, I consider myself successful today if I'm able to push buttons, and if you all go home or back to your respective daily activities and ask yourself, well, what did he talk about, and what does it mean? What does my daily practice mean for newborn screening, and how can we implement change? So disclaimers, of course, I don't have a crystal ball, and we are also not supported by industry partner or receive any other industry funding. These are personal opinions and perspectives, and they're solely motivated by participation in national committees and work groups. And then ultimately, I'm really only motivated by the struggles and sufferings and hardships of all the families and patients with rare diseases. This slide is really the most important slide in my presentation. So considering that there are about 6,000 disorders, Mendelian disorders, and considering that there are about 80% of those have a genetic cause, and roughly half affect children or present with an early onset, that leaves us with about a newborn screening universe of about 2,400 disorders. Now, I don't need to remind you that the current panel are anywhere in the order of 40 to 50 disorders. So just put in perspective 40 to 50 versus 2,400. The current process of newborn screening and expansion of test panels is not agile enough. To allow expansion of the panel by even 10 or 20 disorders at once. So in this presentation, I want to put forward ideas and solutions to bridge this gap. I want to talk about solutions from within the newborn screening system, and I want to present outside solutions. So when we look at the current inclusion, nomination, and selection process, I think this is probably a common observation that the process is incomplete and it does not allow input from the entire rare disease community. The process lacks a broad ideation and selection funnel. The process is biased and often shaped by special interest groups. And here we don't need to draw a distinction between whether these special interests come from large, powerful rare disease foundations or from for-profit companies. The end effect is the same, right? When we listen, when a process is guided by special interest groups, the outcome is always suboptimal. So that means we are either not including the most cost-effective screening disorders into newborn screening, right? Or we spend money where it shouldn't be spent. Payers are often not included in the decision process, and this is just an anecdotal story here that when we had conversations, for example, with Utah Medicaid, we often hear well, we really want to, it would be great if we would have an input because newborn screening not just saves lives. Newborn screening, if applied correctly, has also the potential to save a lot of money. And then we also have to recognize that the process is shaped by inefficient boundaries that prohibit efficiencies. And this is a tough one to deal with, right? Because if we advance forward such hypotheses, then we automatically jeopardize our own career and jobs in a public health environment. But we do have to ask, is newborn screening performed in a public health environment still the best environment for these massive expansions that lie ahead of us? And then we have when we look at the selection, the selection process for the advisory committee, we have to quite frankly conclude that this process is strange and sometimes scientifically unsound. And this observation comes from, for example, from the requirement that we must identify a disorder in a prospective pilot prior for its adoption onto a newborn screening panel. And I mean, that such practice, quite frankly, jeopardizes the progress of the entire medical and scientific community, and it also jeopardizes a rigorous peer review process that is often in place. So what are solutions? Solutions to make this process better. So the number one, my number one wish would be that we are successful establishing a broad, transparent ideation and prioritization matrix with timelines and regular and standardized review processes around it. So what do I mean by that? Well, as a foundation, we should look at the process that Amy Brower from MBSTRN is currently improving. And that is really a funnel where a variety of stakeholders, whether these are clinicians, whether these are industry partners, whether these are payers, they can advance disorders. These disorders would be recorded. There would be a somewhat automated prioritization process around them, and then there would be a regular scheduled review process, and this could be crowdsourced, and we would end up with a much more objective short list of disorders that might truly benefit from the inclusion into a screening panel. We need to eliminate the current nomination process, or at least the inefficiencies that are attached to this process. And we really need to find methods of early payer inclusions. We need to find opportunities to allow for real-time cost-benefit assessments, and maybe even make this process payer-driven. Because in the end, right, there are many disorders where, as a population at large, we would truly benefit from screening for these disorders instead of just dealing with the costs of associated with clinical management and suffering. And we need to have a continuous assessment of newborn screening program costs. It is probably common practice that while we say, well, a newborn screening test costs $100, $150 for our clients, we have to ensure at the same time, right, that whatever we ask for is truly coming back to the newborn screening programs. And we are not supporting like hantavirus screening and wastewater testing or whatever these public health expenditures are, for which we have no common funding mechanism. On the technology side, we really have a lack of proper technology development solutions, and we have thereby a lack of scalable technology solutions. Here again, the status is dictated by solution providers who offer FDA cleared methods and solutions. And while this is not all bad, it definitely comes with a convenience or practicality factor. It hinders innovation. We need scalable technology, but these technology today are not developed rapidly enough. So broad categories here include LC, so liquid chromatography based MS solutions, and whole genome sequencing or whole exome sequencing solution that would be, again, scalable, i.e. gene or disorder agnostic. And we have to realize that technology development, for the most part, does not happen in newborn screening programs. Many newborn screening programs, they are content, happy enough if they can keep up right with their day-to-day operational requirements, but they are far away from actually being able to engage in R&D or development activities. So what could be solutions for this conundrum? Well, solutions could be, again, public-private partnerships or targeted grant programs with very clear objectives. So, for example, this announcement could look like they could solicit specific methodology development projects with very specified outcomes. So, for example, there could be a grant opportunity to target lysosomal storage disorder with a minimum of 10 additional disorders, and to have specific performance outcomes. So that from sample to sample, this cannot take longer than a minute instead of the common practice of 2 minutes to date. And this would be actually in stark contrast to the to a lot of the current pilot program initiatives where we pay states the exploration, for example, of MPS II testing in a sizable population. We also need clear mandates and objectives regarding data curation, and this becomes especially important when we enter the realm of molecular testing. So whenever we think about such partnerships, we need to make sure that if a private entity is involved, that data is returned to the states for secondary data exploration and maybe secondary algorithm development. The next point I would like to touch on is the conflict or perceived conflict between screening and diagnostic or clinically actionable results. All too often, the community is divided between, well, that's screening, well, that's diagnostic, and instead of finding a middle ground and recognizing that finding this middle ground is associated with significant cost savings. So as the number of disorders increases, we have an increasing need for, because these methods are not perfect, we have an increasing need for orthogonal second-tier and diagnostic testing requirements. Well, we have to realize that there's a high probability that public health programs or newborn screening programs are not optimally positioned to do that. That's a very big dilution of efforts. It's associated with very high capital expense requirements and personnel needs. And then, of course, secondary to that, we have we can be faced with very significant cost explosions. Again, there are solutions, right? Solutions could be public-private partnerships or regionalization of resources that would operate under a diagnostic umbrella. And that, especially for small states, this could have very, very clear benefits. The diagnostic testing needs for babies in Utah and Colorado are very similar, right? And just 2 states teaming up would all of a sudden mean, well, you could hire a board-certified geneticist to science out these results and things to this nature. Or you could engage in a diagnostic laboratory partner doing this. Again, there are community models. We can think of co-ops, and there could be economic partnerships, again, between industry partners and states. When we expand newborn screening, we have to be aware of the possibility of associated health inequities. So what does it mean, and what are secondary liabilities associated with this? So when we think about this total newborn screening universe of 2,400 disorders, we will hit milestones where people ask, well, why are we screening for condition A, and condition D has a treatment modality that is really good. So how are we dealing with this conflict as a community? We have to address that because, again, the probability increases as the number of newborn screening disorders increases. We also have to think about fast-tracking disorders with very effective treatment modalities and how to deal with disorders without treatments. It was rather refreshing to see, right, once a treatment for SMA, or treatments for SMA became available, how quickly the adoption of SMA on newborn screening panels occurred. And so what are we doing with disorders where we only have the more traditional disease management rather than curative interventions? So again, the hallmark is here that we encourage radical innovation and national coordination efforts. And we really focus on real-time fractional benefit cost analysis and how they affect patients with the rare diseases, as well as the payer system at large. Again, an angle can be here to work with states where we have consolidated or where we have large healthcare provider networks. Those systems would be ideally positioned to engage in these efforts. Here's an example that I'm not that these visions, right, are not just hot air or blah blah. So NIH announced at the end of October the Bespoke initiative, where they partner with 15 private organizations to increase gene therapy development for rare diseases. And while this is the end of this life cycle, right, once these treatment modalities are effective, it will make sense that we adopt them early before the onset of symptoms, and then we are all of a sudden back in the newborn screening arena. Now I want to shift a little bit, and I want to talk with you about the complementation of current modes of screening operations. What can we do, and how can these seemingly parallelized methodologies converge and in the end support newborn screening? Method development has focused on populations with high diagnostic yields. In these populations, we can quickly see benefits. We can see benefit cost relationship, and then we can see how quickly they adopt, and we can benefit from the operational infrastructures of these methods and investigate or ask questions how they would potentially benefit for newborn screening. So the last part of my this presentation is really exploring one of these seemingly parallel opportunities and the impact for newborn screening. And I want to dive a little bit deeper in the project Baby Bear in Rady's NICU sequencing project, and all of this data is of course public. They have an amazing final report where they list everything from cost to disorders or diseases identified. So just so we are on the on common ground. So what is NICU whole sequencing? Well, in the neonatal intensive care units, right, the cause of sickness is often unknown. This not knowing what's wrong with these with these kiddos results in these diagnostic odysseys. They are associated with very high expenses, management expenses, and they are also very traumatic for the babies and families. So what we do is we sequence the genome of these kiddos and the parents, then we call it trio sequencing. And this has clear benefits, speeding diagnosis, as well as shaping clinical disease management. And this methodology has moved right from a researchy perspective to an emerging standard of care. So a methodology that has moved very, very quickly, right, from esoteric research to a new diagnostic care standard. Well, for those of us, right, who want to see hard evidence, there are numerous scientific and clinical publications now available. One in the American Journal of Human Genetics from July of this year that summarizes the Project Baby Bear and demonstrated improved clinical outcomes and reduced cost. The summaries are shown here, right? This was a really study that had a major positive impact on the population, the NICU population at large, but also at underserved populations. It resulted in significant cost savings, right? And the authors also advanced a general conclusion that this method is ready for prime time. Well, when we discuss such methodologies, there's always we also have to look at the other perspective. Does a new method introduce harm? Again, a study in JAMA Pediatrics this year, where the psychosocial effects of NICU newborn screening, NICU sequencing was investigated in the BabySeq project. And here the authors concluded, right, that in this randomized clinical trial setup, there was no persistent negative psychosocial effects on the families for those who received the methodology, nor among those who received a monogenic disease risk finding for their kiddo. So, I mean, this kind of provides the kind of holistic view that it is beneficial from a clinical perspective, and the harm impact is minimal at most. So let's look let's look a little bit more in terms of the cost saving, and again, why will this be ultimately important for newborn screening? When we look at the cost saving as a function of returning results of this methodology, we see two things, right? So the faster the results, the more savings. Number one. Number two, we had savings that were hard and they can be readily quantified, and these are system savings, so i.e. Healthcare cost savings. But then we also had a significant savings component. So these were secondary costs for families, so more like opportunity costs when parents couldn't work or when they had to provide transportations of this kind. So key outcomes and relevance, again, for possibly for newborn screening. The whole study looked at only 178 babies that met this requirement, so a very small number of cases. 43 received diagnosis, 35 cases were rare, some ultra rare. 57, they may not have received a diagnosis, but the cool thing with such methodologies is that we can begin thinking about reanalyzing these data sets, right? As when, for example, indicated by an updated variant database and things to that nature. 31% of the kids received changes in disease management. This resulted in fewer procedures and tests. These findings and implications were so significant that other states are now adopting such practices, or at least such payer practices. The Michigan Department of Health and Human Services, on August 17th, 2021, they published this bulletin suggesting coverage of rapid whole genome sequencing testing as indicated in these critically ill newborns or young patient population. But again, it's not just public health systems or Medicare or Medicaid systems. Also, commercial payers recognize the need for flipping the bill for these emerging technologies. Blue Cross Blue Shields in July of 2019, you see that in yellow, rapid whole genome sequencing is considered medically unnecessary for the evaluation of critically ill infants or children of less than 18 years of age in neonatal or pediatric ICUs with illness of unknown etiology. Since then, other health plans, this number might be even higher now, 10 other Blue Cross Blue Shields health plans adopted a similar reimbursement directive. So now I want to close the loop and again discuss building technology and ultimately close with the implications for newborn screening. So the RADIS, the NICU sequencing study has shown, right, that diagnostic NICU sequencing is fast and it could complement newborn screening second-tier testing workflows. Of course, NICU babies, they constitute a symptomatic population with a higher diagnostic yield than a normal general population. The benefits of these studies for the rare disease community is hope for a stepwise approach to bridge the gap between disorders covered by newborn screening and disorders not yet covered. And for the rare disease community, such an approach is, of course, an assurance that there's coverage for early onset disorders that coincide with the manifestation of symptoms. This technology is also expandable to other areas. For example, when we look at the entire developmental delay axis, it just makes sense as this goes mainstream, right? That we apply that wherever it's clinically indicated. So now to finally close the loop and end. So NICU sequencing and the impact for newborn screening. I don't want you to go and think like, why is he talking about this? What are the implementations? So the technology has the potential to augment newborn screening. So let's look at the technology development first. As we need orthogonal second tier and possibly third tier, right, and diagnostic testing modality, the fact that we need rapid whole genome sequencing in the NICU, that also generates an complementary infrastructure for state newborn screening programs, and that is twofold. So number one, if states or healthcare system in that state decide to invest in this infrastructure, either through commercial partner or through internal laboratory efforts, of course, this can be used by newborn screening programs who need equally fast turnaround times. However, if a state is not going to make this investment and instead makes an investment in fast courier services to serve hospitals with NICUs, right, with equally fast of these pathways, again, we can newborn screening systems can tap into these resources. And then, of course, from the perspective of the rare disease community, it provides a second route of hope. The current newborn screening program is undergoing this transition, maybe blowing up in some states, right? At least we make parallel investment in technologies that might benefit for either foundations or directly to families. So I want to end here, and again express my hope that you go all home now or return to practice and think about this 2400 to 50 dilemma, and you think what you can do to implement change, and thank you very much.
Thank you, Dr. Rohrwasser, for a wonderful presentation and absolutely thought-provoking. We will now open for questions. Please place your questions in the Q&A tab or the chat box. So our technology sounds like it's being a little bit quirky. We are monitoring both the Q&A as well as the chat box for questions. If you do not see the Q&A, you might try refreshing your screen with the little kind of circular button, usually at the top left of your screen. But we do have a couple of questions already. So hopefully, Andy, you got your thought-provoking intent across. First question is, how is the data managed for the whole genome sequencing? Meaning, who owns the genetic data and where does it live? And I'm assuming this is referring to when it's used for newborn screening.
Yeah, so let me give maybe a little longer-winded answer, right? This is, again, I put this in the category of opportunity, right? As we begin thinking about that, there are many ways we can do that, right? But we have to have a discussion and conversation process as newborn screening system, as people working for newborn screening programs, and then again working with healthcare providers, and working with whatever the entities are who perform this screening. That we generate infrastructure so genetic data is coming back to under a safe umbrella that makes the data usable for at least 3, 4, 5, 6 years, right? And usable for reanalysis.
Very good. Question number 2, is there a web resource that can provide information about where and how newborn specimens get tested? For example, a tribal nation healthcare facility participating in newborn screening testing centers.
So again, maybe go from top to bottom, right? There's in general there's pretty good information, right, from APHL and APHL resources, new steps with regards to what states are doing. If there are specialized questions, right, and folks cannot find answers, what I would recommend reaching out to. I have my email address at the end. Reaching out directly to us, reaching out to the programs, and we will do anything to guide you in the right direction to shed light into this.
Very good. Question number 3: would you consider newborn screening testing genetic testing?
Well, that is kind of a little silly question, right? Because let's look at CF, and so screening for cystic fibrosis, right? We have an integrated algorithm where we have a biochemical marker, IIT, and then we have mutation analysis, and then we go to a gold standard, which is, for example, sweat chloride testing. I think we should refrain from being categorical, because it doesn't help. We should adopt a pragmatic approach, and we should say newborn screening is a system, and we start with a biochemical test, and we complement whatever necessary with whatever methodology, right? And there is no one fits all answer.
Yeah, I think probably the question sort of is bringing to light the paradigm shift that we've had from biochemical and biomarkers for typical newborn screening to now much more molecular testing, that is really changing things. So I have to ask a question coming from a clinician standpoint as a geneticist. How do you see the current genetic workforce and probably public health workforce being able to adjust and adopt to all the results that we might get back from this with this sort of testing?
So that's a very good. I think that's a very good question, right? Because I feel neither the clinical workforce, right, nor the workforce in newborn screening system, right, is adequately prepared to deal with this today. The second thing is we don't have enough. Each respective discipline has the workforce is simply not there. And we also have to be, and then the third comment is we cannot just train, we cannot just take a laboratorian in a newborn screening program, right? Or a clinician who has been who has been doing this for 10, 15 years and all of a sudden say, okay, we put you in a course and a year later, right, you're an expert in these things. I think these are concurrent efforts that need to happen. They needed to start yesterday. So we will be prepared for what is going to come.
Absolutely. I think too, the question of equity is really going to arise from the standpoint of, given our system is state to state, you might have a state that's very progressive and moving toward screening all kinds of disorders, and another state that is much more slow to adopt that, and then you end up with that equity across state lines that makes it really difficult, kind of patient per patient. I think that might be really true if we go to really broad-based screening, like with genomes and exomes. What's your thoughts on that?
Well, again, I'm usually an optimist, and this situation, right, lends itself perfectly for these to explore these cooperative models, because I alluded to this during the presentations, right? I mean, second-tier testing or these interpretive services or even diagnostic services, this could be done in a decentralized model, where states should collaborate, right, and benefits from economies of scale to make the most out of it, right? To be cost effective, to have fast turnaround times, right, and to accommodate the scarce resources, especially in the from labor perspectives.
Absolutely. I love the idea of sort of regionalization of second tier and third tier testing. We have a couple more minutes and a couple more questions. What are some examples of how management changed for NICU babies with a diagnosis made by whole genome sequence? Was it most often the palliative care that was indicated?
So that's, again, a very good question. And I would encourage you to look at the Rady's final report, because I went through this report and I looked at the disorders identified. And for example, one thing that did strike me was I think in this cohort there were actually 2 or 3 SMA cases that were identified for I guess before the onset. I don't remember when California began screening for SMA, but so I guess the most significant impact came from having a diagnosis sooner and preventing unnecessary tests.
Absolutely. And then the last comment we have is sort of more of a comment, I think, but it says agreed. I think this goes back to the earlier question I possibly asked. Isn't one of the criteria for including a test that there needs to be infrastructure to handle a positive result? How would the infrastructure hold up to having all of these positive results if we increase screening? So similar to the previous question, I think.
Yeah, and again, right, we cannot just increase screening, right? We have to increase screening and concurrently do it really, really well, right? If we are not doing it well, then we overwhelm the system with referral cases, with a lot of false positive cases, and that we cannot afford, right? So but again, right, in the community, there are enough smart clinicians, there are enough smart biochemical geneticists, there are enough academic researchers, right, that we as a community, we should be able to address this problem. What we cannot do, we cannot put our heads in the sand and say, oh, there's so many problems, let's kick it down, let's kick the can down the road.
Absolutely. Very good. All right. Thank you, Dr. Rohrwasser, once again for your excellent presentation. We appreciate your participation in our Genetic Summit today.
Thank you.